Good afternoon. I'll just wrap up this session with a few interesting cases that highlight unusual applications of cardiac MRI in the management of congenital heart disease. Whenever we think of pediatric cardiac MRI, what jumps to the mind is usually the RV volumes on for Epstein, pulmonary regurgitation fraction post-ICR, your run-of-the-mill patient with myocarditis, or even the odd striking cardiac tumor. However, cardiac MRI presents us with the diagnostic armamentarium of flow quantification, precise ventricular volumetry, pattern recognition that we've been talking about so far, tissue characterization, and even perfusion imaging, which is when used together can have myriad clinical applications in pediatric cardiology. The first case I'm going to talk about is an ex-preterm who had a neonatal diagnosis of a moderate fenestrated ostium secundum ASD with pulmonary hypertension secondary to lung disease of prematurity, was discharged home, but was readmitted at 5 months of age with a polyviral respiratory infection with decompensation and RV failure. The echo showed a dilated dysfunctional RV, moderate TR, and a bidirectional shunting ASD. The patient needed stabilization with inhaled nitric oxide and non-invasive ventilation. Could be weaned to oral pH medications, but then again had an episode of right upper lobe collapse within a week and a consequent RV failure. So this was when a cardiac MRI was ordered for precise quantification of the shunt from the ASD and the amount of volume overload that the RV was facing. Even at baseline, we saw that there was a significant left to right shunt at the ASD with a QPQS almost 4:1, which increased significantly with 100% oxygen and inhaled nitric oxide pulmonary vasodilation. So this patient was then, based on this, sent for surgical ASD closure with subsequent improvement in RV function and even the need for pH medications. The second case is a rare case, anomalous aortic origin of the coronary artery. The first, this was actually a patient who was evaluated for just an innocent murmur in infancy, and the echo was suspicious of anomalous coronary origin. The initial CT that was done just for evaluation of the coronary anatomy showed us that there was a single coronary arising from the anterior commissure, which bifurcated soon after its origin into the uniformly narrow RCA, and the left coronary had in fact a narrow segment just after its origin between the STJ and the proximal LPA, which was suspicious of an intramural course. The follow-up for this patient, because these patients, according to guidelines, merit coronary reimplantation or osteoplasty. So these are complicated procedures, so it is better to do them. The surgeons prefer to do them after the first decade of life. So we followed up this patient based on yearly dobutamine stress MRIs because the patient was asymptomatic. We saw that the patient continued to have no late gadolinium enhancement. Stress perfusion imaging was done with dobutamine, and this turned out to be normal on our surveillance. And there were no regional wall motion abnormalities, again, on stress testing. So we could put this patient on regular surveillance and will be operated on after the first decade of life, and the surgeons are more comfortable doing it. A very common indication for cardiac MRI in pediatric cardiology is deciding on univentricular versus biventricular surgical routes in borderline hypoplastic left hearts. This was a patient with a shown complex variant mitral stenosis, bicuspid aortic valve with a narrowed LVOT, had already had a PDA stenting with bilateral PA banding and a fenestrated ASD closure for LV recruitment. This MRI was then done thereafter at 5 months of age for decision-making about the route of surgery that was to be taken. It confirmed that the LV was actually hypoplastic with a very small EDV of 26 ml per meter square. But the reassuring part was that the ascending aorta flow, which is an integrative index of left ventricular performance, irrespective of the left ventricular outflow tract obstructions, and a value of more than 2 liter per minute per meter square is pretty reassuring. And there was no evidence of endocardial fibroelastosis on late gadolinium enhancement. So this patient was then sent for a biventricular repair. This is a really interesting case which shows us how flow patterns can be used for diagnostic purposes in pediatric cardiac MRI. A patient with dextrocardia, isomerism, RV dominant but balanced AV canal defect. This was at 1 year of age. The patient was sick, blue, and we already saw that the echo had severe AVVR, and that was one of the probable causes for the decompensation in this patient. But we wanted a cardiac MRI for better anatomic and hemodynamic delineation. Aorta was from RV. There was essentially no antegrade flow across the pulmonary artery. There was no discrete stenosis in the glen that had been done as an initial palliation. Ipsilateral hepatic venous drainage, left pulmonary vein obstruction, and the 3D reconstruction showed us that there were obviously multiple collaterals. So something was wrong in this initial glen palliation. This is a T2 lymph sequence that is done essentially to look at the lymphatic congestion, and this showed a pretty bad picture. A lot of increased signal in the mediastinum and the retroperitoneum, and also in bilateral supraclavicular regions and the mediastinum. Evaluations that we did using phase contrast was actually very abnormal. Hardly any antegrade flow across the left glen, and most of it was retrograde. The pulmonary artery flows that we see in yellow and blue were surprisingly lower, a lot lower than the pulmonary vein flows and the red and green flows. And also surprisingly, they were in the same direction, which basically means that there was entirely retrograde flow in the pulmonary arteries. The cath confirmed this. Multiple venovenous and arteriopulmonary collaterals with a raised PVR, and essentially there was no flow from the glen to the pulmonary, the left pulmonary circulation at all, and it was entirely collateral dependent. Another example, keeping with the theme of flows in cardiac MRI, a patient after Fontan completion for tricuspid atresia, who'd already had a fenestration closure, was referred for cardiac MRI for investigation of a mild persistent desaturation, a saturation that hovered between 88 to 90%. The fenestration was still in place. There was no residual shunt across it, which was determined from upper and lower Fontan flow measurements. And the Fontan circuit was essentially unobstructed. But there was a significant finding when we injected gadolinium from the left arm for the angiogram. What we see from here is that the glen flows almost entirely to the right lung, and the IVC through the Fontan conduit flows to the left lung, which basically means that the right lung is essentially not getting any hepatic factor, and that predisposes to AV malformations as a cause of the desaturation here. I'll end up with two dramatic but cases that could that cardiac MRI helped determine the management for. This is a Kawasaki patient with giant aneurysms in both coronary arteries. We already saw an echo and was confirmed on MRI that the patient had extensive myocardial and myocardial thinning in the apex and dysfunction. But late gadolinium extensive enhancement and fibrosis pushed this patient towards transplant as the only possible management. Cardiac MRI is an excellent tool for serial surveillance of patients with bicuspid aortic valve and aortopathies. So this was an adult with poor echo windows and essentially an innocuous looking transthoracic echo. The 4-chamber on the MRI showed us a suspicious looking cystic lesion already. The arch was essentially normal on cine imaging. The bicuspid aortic valve, however, showed us a really sinister looking sinus valsalva aneurysm that had essentially not been diagnosed earlier. The patient was referred for an urgent surgery, and we saw a similar, the same picture of the aneurysm on the intraoperative TE. That's it. That's all I have. And I'll take this opportunity to thank the wonderful cardiac MRI team at the Stollery Children's Hospital who shared their all their knowledge with me. Thank you.